frequency of 4Hs and 4Ts that I'll speak about later on. So we can cardiac arrest rhythms. Again, I appreciate that maybe teaching you this that you already know. So this will be an asystole. This is an unusual one. Here you can see what I call P waves, but you do not see any QRS or T waves. This is what we call P wave standstill or ventricular standstill. It's that they say node is firing, hence with the P waves, but there is no activity below the AV node. And this can eventually lead to asystole. This is what we call ventricular standstill. So it's important to recognize this rhythm as well. This one, you can see some cardiac QRS complexes, so you know there is cardiac activity, but there's no signs of life. So this will be pulseless electrical activity. This one is quite a broad complex, quite regular, so we know this is an ET. And then in the absence of any signs of life, then you know it's pulseless VT to shock the patient. This one is more complex, quite erratic baseline. You know this is ventricular fibrillation. So talking about the 4Hs and 4Ts. So if you're the trauma or the team leader rather, whilst everybody is doing the things, this is what you articulate. So hypoxia, how can we correct that? So oxygen. If you do the expertise, I always put an endotracheal tube, but majority of the time the laryngeal mask is sufficient enough. And there's some good evidence, and the evidence comes from what you call the AOA trial. It was a large randomized control trial all over the world, both in high income, medium income, and low income settings, and there was no difference between laryngeal mask or endotracheal tube in terms of cardiac arrest, automatic cardiac arrest, in terms of 30-day, 60-day mortality rate. What about hypothermia? So if the patient has got hypothermia and we want to re-warm them, so if there's any wet garments, take that off, insulating folds or blankets. There is a few caveats. So if the core temperature is less than 30 degrees, we wouldn't give them any medication until it is 30 degrees. Because the medications like amiodarone are not effective in a hypothermic scenario. How do you actively re-warm? We normally, if you do have humidified oxygen, warm that up. You would catheterize patients, flush it with warm saline, or give them warm saline IV infusions. The other caveat is if less than 30 degrees, we only shock them to a maximum of 3, because shocks are not effective in a hypothermic environment. Hypovolemia, if there is catastrophic bleeding, we just want to apply direct pressure. Or if you think that they're bled from a fractured femur, you want to straighten that in traction, because we know anatomical correction will stem bleeding, or you want to give the volume replaced, so either with fluids or blood. What about toxins? So if you may have seen a patient who you worry that there's an opiate toxicity, because either when you saw that their pinpoint pupils go speech red, and then they went into cardiac arrest, give them naloxone. Mentioned chemothorax, again, this would be the setting of trauma, or it could also happen as in tall, lean men or smoke. Again, it would be easy to diagnose in terms of the trachea will be deviated away, asymmetrical chest movement. To decompress is as simple as you get the largest gauge cannula. There's two methods. There's one which is the second intercostal space, mid-clavicular line. Depending on people's pectoral muscles, soft tissues in terms of adipose, that is not always that effective. What we do advocate for is the fifth intercostal space, mid-axillary line. Because the majority of people, no matter how high their BMI is, it's much more accessible. So fifth intercostal space, mid-axillary line. And hyperkalemia, so again, depending on your capabilities, whether you've got a venous blood gas that's available to you, if the potassium is high, you want to give them calcium chloride or calcium gluconate just to stabilize the myocardium. But a few tips, because I do a bit of pre-hospital medicine. If you see somebody with a dialysis, a fistula, you're more likely that they suddenly had a cardiac arrest, that we know is more likely because of hypokalemia. So we preemptively give these patients calcium chloride, even without having any potassium results at hand. And if it's thrombosis, if it's suspecting PE or a cardiac event, we can give them systemic analytics as well. So that's an overview of 4Hs and 4Ts. So that's cardiac arrest. What about this peri-arrest scenarios where somebody is quite tachycardic or somebody is quite bradycardic? So how do we recognize it? How do we treat it? So this is a flowchart that I borrowed from yourselves. I'll break it down. In your case, it says tachycardia of 100 and 150. Research Council says tachycardia is defined as 120. I would go for 120 because I want to have a lower threshold. So I don't want to wait until it's 150 and it's too late. So what we normally do, if somebody is tachycardic, you want to do an ECG, do basic A to E examination, give them supplementary oxygen, obtain IV access, and treat it in irreversible causes. Ideally, have venous blood gas to check the HP, potassium, sodium, glucose. And we look for high-risk features. So these are somebody who's had a shock, so when their blood pressure is low, they're tachycardic, they're tachypneic, had a recent fainting episode, they had symptoms or signs suggestive of myocardial ischemia, either who's in a patient who looks grey, who just who smokes 20 cigarettes a day, who's diabetic, but who came in clutch either with Levine signs, clutching their chest. You know highly likely this person is had a cardiac event. And if you see tachycardia, you need to be worried about that. Or somebody who's got severe pulmonary edema, or somebody who immediately who is post-ROSC, you know that this is an unstable tachyarrhythmia. And the way to treat that is to give them 3 synchronized shocks back to back. And if that's not successful, you want to give them amiodarone or procainamide. And again, this is endorsed by yourselves as well. What about this one that does confuse a few people in terms of if somebody has got a broad QRS complex and it's quite regular, we know it's ventricular tachycardia. And ventricular tachycardia can both be a peri-arrest rhythm where they have some signs of life or a sign of life. And the moment they don't have a sign of life, then remember, you need to switch your cardiac arrest flowchart because you know that they need shocking. And usually VT will be in the context of a few things, either ischemic heart disease or somebody who has electrolyte abnormalities, so either magnesium issue or a calcium issue or a potassium issue. There is a caveat because a few times patients with SVT, with bundle branch block, will look like a broad complex ventricular tachycardia. So what I advise is, if you have a patient in front of you who looks grey, who is tachycardic, tachypneic, you will not worry whether this is an SVT with bundle branch block. You treat it as a VT. And ideally, the way you do that is you want to give them synchronized shocks. And if you think that sedating the patient is too high, you can put them on procainamide or an amiodarone infusion. So we want to treat it as worst case scenario, which is ventricular tachycardia. What about bradycardia? So again, you want to assess the patient. So bradycardia is defined as 60 beats or less. So again, you do your A2E, give them oxygen, do an ECG, and if there's any high-risk features, hypertension, or signs of shock, acute heart failure, you want to treat it. The way you do that is atropine. So it comes as 500 micrograms, and you can give it up to 3 grams or up to 6 times. And if failure to do that, you can put them on dopamine infusion. But I would say what they need is percutaneous pacing. Or if available, you can do transvenous. That involves putting a subclavian line, and then you can pace them using a temporary pacing wire. And this is because once you've achieved ROSC, you want to make sure you optimize the patient's care in order for them get what I call the secondary or tertiary treatment. I'll break this down a bit further. What is important also to do once you've lost is, again, the APC. So keep thinking of this Jackson 5 song. You'll protect the airway, so ideally then escalate if you had an LMA, CO2, an N-type of CO2. Blood pressure, we want to maintain a MAP between 60 and 65 to ensure auto-regulation to key organs, so your kidneys, your liver, your heart, and coronary perfusion as well. If you think somebody may have had an ST elevation MI, they need rescue, occasional coronary intervention. So we work in Jersey, we don't have a catheter lab, so we will send these patients off to another centre in the UK for this. And consider whole body CT. So I've had episodes of patients with subarachnoid hemorrhage who presented